between the layers of the vessel. So you never know 100% really where the vessel is. And because it's faster, because I can do from one insertion point, my insertion point is almost at the, you see here, oral commissures. If you bruise them there, women can cover it with the makeup, it's not so bad. Injecting subdermally, at least 25 G can do. I sometimes use 22 as well, but that leaves too big channel for the lips and destroys the septate. Injecting first subdermally along the mammalian border, and then you change to the product, this is bilateral lips contour, and then you change to something that gives you more volumization, injecting subdermally again, along the dry-wet border, for the projection, eversion, and volumization. And you can also, by same thing, put a little bleb here, don't inject just the line. For the median tubercle, then you leave a little space. Some people put like a also like a suture there, and then injecting as much as you need, either in a little boluses or in a linear threads, down to the oral commissures, and of course never injecting too much there, but I like to go perpendicular here and inject a small bleb. This is my favorite technique because it's faster, patients don't bruise so much like with the needle, and it's safer regarding the vessels, so it's never 100% safety. Because why? Look at this study, Sonia is here, this has been just recently published by Sahar and Sebastian and Ols. When we look where the product is on the cadavers, in 60% of the cases, application using a needle placed injected product in endangered location, whereas 57% with the cannula was also placed in an endangered location. But with the cannula, it's much more difficult to penetrate the vessel than with the needle. I have shown you that. So, and therefore it's better. Don't look just at the lips, look at the bigger picture. Even in younger patients, I did her lips. And by the way, this was the patients that I did one side with the needle and one side with the cannula, and you see there is no symmetry if you do it properly, combining lips, contour, and shape. But if you don't correct her chin and the labiomandibular triangle, with, for example, volume, like Yanni has done yesterday, nothing will happen. Look at the piriform fossa. So this patient came to me and said, oh, can you inject more in my lips to hide the nodule? No way. I always told you yesterday, first dissolve it. So what I have done, I injected hyalase into that nodule, but I injected volume in the piriform fossa and the midface. And look at her lips. They actually look bigger now, though I have injected hyalase into her lips. So lips alone is never enough. In all the lips, it's the same thing. Patients usually come for the perioral lines. So we have these different cores. We can inject those if the elastosis is not severe. We have the beautiful blanching technique, and you see how superficial the blanching technique is. You can use soft or a balance. Little drops introducing just the bevel into the dermis. And you will not have lumps and no blue lines. And this is a patient where I have something differently. I injected the midface, and then I used a little bit, only 0.3, what I had left of radius, diluted 1:1 for the entire perioral area. And then for every single line, bilateral balance and soft, I used the balance with 30G needle, and then on top, with the smaller invisible 32G needle, soft. And look at this patient after 7 months later. So by improving the skin texture and the lines, combining diluted radius, but not going into the mammalian, remember that once again, it's just for the skin, you can actually achieve very long-lasting results. However, if you have a patient like this, you need skin resurfacing. And last but not least, full face, heavy face. Can you do my lips? I thought, come on, if I do the lips and these patients become them bigger, the entire face will look more black. So you have to do the contouring and the things, and the mid-face. Very difficult case. She came for the lip, believe it or not. And you think, come on, I will do everything else than the lips. So, and really, I could convince her. And the last thing actually that I've done was a little bit of the balance for the contour and a little bit for the volume. Why volume in the lower lips? To be honest, economically. I have injected the entire face. When I'm going to open a new syringe, no. So if I have 0.3 left for the volumization of the lip, of the volume, then I will take this and you see the result. So think about the lips like just one part of the face, but it's one that most frequently attracts the attraction from your other side partner or on the pictures. Don't think just the numbers, think in the little point in the structures. Young patients is a rather shaping volume and contour, but also in relationship to the entire face. And in old patients, again, multi-layer, multi-model, individualized treatment approach, and never overcorrect. Thank you very much.
Thank you very much, Tatiana. I want to congratulate you. I'm going to tell you something. When I saw the program 35 minutes on the list, I was amazed because what is she going to tell us during 35 minutes? I used to tell the anatomy of the lip in 2 minutes. So congratulations, 35 minutes was fantastic. Do you have any question? We don't have anything here. If not, I have a question.
Yeah.
You mentioned the Paris technique.
Yeah.
I'm French, I'm living in Paris. I didn't know, because I do this perpendicular technique, that it was from Paris. Can you explain why Paris?
To be honest, I cited it from the expert to expert books from Patrick David. So I actually use it a perpendicular technique.
Yes.
Paris or Merz had also kind of like a lip blush technique, but it's not like longer promoted, so you find for the same thing many different names. But this is where I cited it actually from the ETB book.
Very good, thank you. I think this technique perpendicular that is not very, logical at the beginning because we want to be parallel and perpendicular is really, I mean, when I changed from parallel to perpendicular, it changed dramatically my results.
I always explain it like building a house. If you want to really have something very high and stable, you need a vertical support. But then at a certain point you need to level it up and then you do it.
Absolutely. Very good. We don't have any question. If you want, just in case to be more interactive, to take a microphone, you are very welcome. Otherwise, maybe we will ask the next speaker, Gianni. Gianni is here?
No, Gianni is in the backside room. Gianni, can you hear us? Because he's injecting.
Yes, I can hear you.
So you have tiny, little, thin lips to use a lipstick on it. Am I right?
Well, yes, that was the idea, except when I met my patient this morning, I said, well, it seems like there is already some product in your lips. And she's like, yeah, that's right, I had it done last October, I think. Was it October? Yeah. And so she's not a naive patient, but actually, she's a very interesting case. Let's have a look at what we can see here in her case. All right, so if you could zoom in, then you can see that if you stop right there, right, you can see she actually has pretty good lip volume. But what to me is striking is that you see here on her left side, there is a bit more projection of the lip than on the right side over here. But if you look even further laterally, you see that there's actually, the lip is disappearing and the mouth corner is going down, while on the right side it stays visible and the corner of the mouth isn't going down that much. So this is actually a difficult case because symmetry, of course, is an aesthetic goal, an aesthetic idea. Now, if you zoom out from the mouth, you can understand, if you look straight to the camera, you can see that especially on her left side, there is flattening of her anterior midface. And I can show that by looking from the side, you can see definitely she's quite empty here. Also, you compare that to the right side, over here she definitely has emptiness too, but I think a little bit less than on the left side. So that could explain the inferior repositioning of the oral commissure and actually that superior jowl fat compartment going over that oral commissure. Can you show us your teeth? All right. Now, if you look at the teeth, you see she has beautiful veneers, but if you look closely, you can see that the canine tooth on the left is actually projecting more than the canine tooth on the right. Close your mouth. And that can explain why over here, there's more projection, more eversion of the lip than on that side. Show your teeth again. Now, if you look beyond the canine tooth, you see that her first molar over here is actually much more inside than on the other side. So over here, on the left side, there is less dental projection and also less dental root projection, let's say skeletal projection. Relax your lips again. And that explains why, even though there's more projection here, there's less projection more laterally. So definitely bony support, the skeletal support, is important in her case, and therefore we shouldn't focus only on treating the lips, but actually also the anterior midface and deep maxillary work first before we get to the lips. So now he can relax and lay down. So what I'll do is I'll start.
Yanni?
Yes.
Can you ask her once again to smile? Sorry, you just played it on.
Sorry.
But I think she shows exactly what I was talking about. You know, when she smiles, smile again. Her upper lip almost completely disappears. And you see her beautiful veneers, and you see even a little bit of the gingiva there. So this was exactly when I was saying that you sometimes need a combination also with botulinum toxin in these patients, because how much product you inject, she will always invert it and will never really show the entire power of the projection of the filler.
Yes, Matt.
Yanni, you hear me?
Yeah, of course.
I have a question. I think this is a typical case of class 3, both dental and skeletal. So it means retrusion of the maxilla in comparison to the mandibular. So my question is, do you consider also to inject the piriform? Because when we have a retruded position of the maxilla, maybe she could benefit from a piriform injection. It's like...
I think it is a fantastic idea, Matt. And you know what, I think she would definitely benefit from anterior projection of her cheek, definitely piriform aperture. And looking from the side, you see that, I mean, her, how did you call that, Tatjana? Her tick
finger trap.
Finger trap.
Finger trap,
Test.
that's right, the finger trap test. There's definitely room for anterior projection over here, but I think it's mostly because of pogonium being quite forward. So I think I wouldn't want to project her lips too much, but there's definitely room for some anterior projection. You can see there's definitely in the piriform area, there's room for anterior treatment. And so I think maybe if we just start with a cannula from here, we can advance the cannula subsmas to the piriform area. Can you kiss, blow a kiss to the camera? He's sending you kisses, guys. And actually, so do it again. And so you can see that there's a few areas where actually the vermilion border is a little bit fragile over here. So I would relax. I would even though you know for the aesthetic result, it is not truly necessary to augment the vermilion border. I would place just a tiny bit of bilateral balance. I think in the vermilion border. I will probably work on the lateral part of the vermilion over here and the medial part of the vermilion over here. And I don't think it's necessary to work on the vermilion border of the lower lip. However, we'll have to see after treating this part if it's necessary to still treat oral commissures. Any more questions, guys?
No.
All right, shall I start then?
Yes, please.
All right, so now you can lean back and relax. Yeah, thank
You could actually see from the profile really how deflated her mid-face is.
Okay, I will start with giving you a little needle stick, okay? 1, 2, 3. Okay. Thank you. Could you give me that volume under 2550? Yeah, thank you. Thank you very much. So I'm starting with bilateral volume. To find my entry point, I just squeeze a little bit until I see this tiny drop of blood. So I enter the cannula through the skin. And I lift up to go through smiles. Click. And now I'm in the deep layer. So this is, the cannula tip is now in the deep medial cheek fat compartment. And I'll just start giving her a little bolus, about 0.1. I've stopped doing boluses of more than 0.1, so that is really my maximum. And another bolus of about 0.1. I move a little bit more inferiorly, and another bolus of 0.1. Now my cannula tip is right here. We know that the facial artery is running subcutaneously over here. So we are in the, let's say, relatively lower risk area if we are here below the smiles. Now I'm going to advance the cannula to the piriform area. And I feel the cannula tip just below my finger right now. And I am not pushing it through any resistances. But maybe it's interesting to have a look if I can show you the visibility of the cannula tip. It's not really easily visible, but you can see over here. Maybe you can see it. Can you see it? You can see that the cannula is now in the deep fat, submuscular fat of the upper lip, right? Right there. Did you see that, Tati?
Yes, we could see it very nicely. I mean, we didn't see your cannula. That would be possible with 22G.
Would that be possible with the 22G?
It's simply bigger, you see it easier.
Oh my God, this 22, okay, let's change to a 22G, so because I don't want to hear any more of the Chana talk about the 22G.
Gianni,
Yes.
very interesting technique of piriform with the cannula. I mean, you know that we can do that also with a needle. Personally, I do it with a needle because I want to be short, straight to the point. You go from lateral. The bone is not flat. You have convexity, concavity, then a little bit of convexity. So what is the main interest of this cannula technique compared to a straightforward needle injection?
Well,
On the bone, of course.
actually, you know, you can do whatever you like. I mean, the cannula technique, of course, it's quite easy. And, you know, this entry point will allow you to inject in the anterior midface. And, you know, by pushing through, you can also reach the piriform area. So, but, you know, of course, it's also possible to go there with a needle. The advantage of the cannula is that the product will stay in this anatomical layer. Now, injecting in that single anatomical layer is not something per se that is absolutely necessary. But what you will see with a needle injection, and maybe we can switch to needle, is that in the end, if you inject with the needle, going straight down to the maxilla, that the product will actually, when you start expressing the product from the syringe, from the needle, then the product will start to follow the path of least resistance.
Okay.
And that means it is going to go back towards the surface. So this is probably your technique.
Exactly, yes.
1, 2, 3. Go straight to the bone.
And you see that Yanni is actually not going perpendicular in 90 degrees, but about 60 or something like that, towards the nostril actually, because to get as far as possible from the facial artery. And also, I like that as well because in my experience, it helps you to narrow the nose a little bit as well.
Yeah.
So for all my nose patients, actually, I very frequently do it.
And you do it with cannula or needle?
To be honest, even if I'm a cannula girl, I do this point sometimes with this, sometimes like that. If I'm doing a nose, then I do it because I do the nose with the cannula, but the piriform, then I do it with the needle. I just use a 30G with the collateral volume, small needle, small channel, small retrograde flow as we said, and you also have a lower retrograde flow if you don't go with the 90 degrees as we have shown. And if I do the mid-face, then I sometimes do the cannula as well, because just I don't want to, to do another puncture in the patient. It's less painful.
All right, so you see now that you definitely see that there's an improvement. There's less shadowing over here. There's a bit less depth over there. But do we see a big difference in the position of the oral commissure? I think you remember that this oral commissure was quite a bit lower than that side, right? Because we saw that the molars were actually much more inside. I think we have now managed.
Can she smile, Yanni? Because
Can you
it's
smile?
sometimes better when she smiles, the seat's actually better.
Yeah. When you smile, try to mean it. Yeah, see, that's the one that we were.
Can you ask her to activate DO?
Yeah.
I mean, to pull down the mouse button? Yeah, look. Even when she swallows, she activates the DO. So there, look. So without injecting the DO and probably even the mentalis, maybe even the platysma, these patients will never have really completely upwards directed oral commissures. How much will you put whatever you like?
Okay, so I'm gonna switch products. You can lean back, and I'm gonna make a little can I have the disinfection, please? And I'm gonna make a little pre-hole here at the oral commissure. 1, 2, 3. And you know, this is very close to the commissure itself, so it's very far away from that facial artery. And so that should be a good place to enter with the cannula. Can you open your mouth? Okay, so usually, and I'm right-handed, the left side of the lip is the most difficult side. Now I'm actually just in the subcutaneous tissue, and I go with the cannula through the muscle. And over here, as you can see, I am now in the submucosa, right? So my target is that first molar. You see over here, there's a cannula tip, right? Now, I realize that the superior labial artery is running horizontally. My cannula is going vertically. So actually, when the facial artery should be subcutaneous over here, and a vertical direction of the cannula is therefore relatively lower risk, but still, I have to take into consideration the possibility that even though the superior labial artery is supposed to be horizontally here, there can be loops and it can be variable. There's about 80%, what you say, Tati, 78% chance that the superior labial artery is actually running in the submucosal area, so that is definitely where we can expect it. So over here, I'm starting to inject a small bolus, slowly, 0.05, and reposition, a little bit more natural. Here we go. .05. All right. And as you can see right now, that lateral part of the lip is becoming more visible. Okay, so I think that is enough for deep augmentation. I would like to just now move to the, let's say, more like standard lip augmentation technique and go with bilateral intense to deep vermilion. Can you open it a bit again? So I've just stretched the lip, and very gently I'm going to rotate that syringe and pass through, like if there's any resistance, I don't want to go through the resistance, I just want to gently advance the cannula through the tissue without actually risking hematoma. And it's always good to really check the position of the cannula, because I want to be in the subcutaneous area and I want to be in the dry part of the vermilion, because if I would go to the submucosal, the wet part of the vermilion over there, then there could be an extra swelling that could be visible. So a very gentle retrograde linear thread of about 0. I would say, 0.1 in her case is enough. How are you feeling? Good? Okay. Not too painful. All right.
Yanni, did she have any topical anesthesia for the
Okay, let's have a look.
lips?
So as you can see, slowly she's getting a little bit more volume. And I think what we have to do still is do just a little bit of oral commissure improvement. And can I have that intense back, please? Can you lean back again? Thank you. So we'll do that from the same entry point. So
And I like that because you don't have to do so many punctures. You do it from the same point, and you can assess so many different areas very well.
Exactly. And can you open again? Sometimes it's easy to use your fingers to push out, the oral commissure in order to control the depth of the cannula better. So I'm in the subcutaneous plane. I'm not submuscular or anything. And I'm just below the lip, right? I just want to push up that commissure. Okay, close again. See, now we're getting somewhere. It's becoming nicer and nicer. Can I change to bilateral balance, please?
Gianni,
Yes.
we have some questions. Actually two. One, let's say, regarding the techniques, and one regarding surgery.
Okay.
When do you recommend surgical lip lifting? You are not surgeon, you are aesthetic physician, but do you indicate sometime surgical lip lift when you have, for example, more than 20 millimeter between the base of the columella and the vermilion?
Yeah. Actually, I don't count the millimeters, but I'm just looking at the proportion. If there's a very, very long upper cutaneous lip, then definitely that would be something that I could be recommending. Now, like Tatjana, I almost never use a 27 gauge cannula anymore, but this is one of the very rare exceptions where I still use the 27 gauge, and that is for the treatment of the vermilion border. I like to have a very sharp, defined vermilion border, and I go all the way up to the cupid's bow. And at the tip, I start to inject a little bolus, 0.025 or something, and you can see that it's going medially from there, right? And then a retrograde linear thread. And in total, I almost never inject 0.1 or more, right? It's usually less because I just want to have a little bit of definition, a little bit of contour.
Yeah, but what is important is you've seen how superficial this cannula was. It was actually scraping on the dermis. So as superficial as possible. Right?
As superficial as possible. And a lot of our friends are still, like even Kate is doing a vermilion border with needle. And because she feels that she can even be more precise in defining that contour.
I never get a continuous line with the needle wherever I inject, so therefore I'd rather put one line.
Yeah, so just to finish, because I guess I'm taking too much time.
Yeah, we
I'm
have
gonna
1 minute left.
I'm going to go to the lower lip, and the lower lip is quite easy, quite straightforward, So again, no force. When there's resistance, just go back and re-advance while rotating that syringe, right? So over here, I'm just in the medial part, just lateral to the midline. And I inject 0.05 in a short retrograde, re-advance. 0.05 in a short retrograde, re-advance. And I think another 0.05, and that should be enough. And so, as you can see, I am not injecting the vermilion of the lower lip here in the lateral part. So I just want to accentuate that nice, sensual, attractive little squishy cushion she has in her lower lip there. Okay, can you see that?
Very nice.
All right, so I think with that, I would like to hand it over back to you, Tatjana and Matt. And
Congratulations.
thank you very much, guys.
Looks very good. Looks
Yanni.
very good. Yeah,
Yanni.
if you would have just one question from the audience also. If you would use needles with bilateral lips contour or bilateral lips shapes, which size would you use?
So
For the lips.
with Bellator Lips Contour, I would use a 30 gauge needle, and with the shape, I would use a 27.
You see, I use for everything 30G needle. I use even intense with 30G needle, because if I only use a needle, it's a little bit more tough, but it works. But
Yeah.
it doesn't work with every single needle brand.
But you have very strong fingers.
Of course, I train my arms. Come on, I learned from Michelle Obama.
Yanni,
Yeah.
Great job, Yanni. Thank you. And you see now, he had a young patient, and it's even in young patient, it's not just about the lips. If he wouldn't have to do the mid face and the maxilla, and she could actually even have more, but we don't want to change her too much, the big lips would actually look very weird.
yeah. Yanni, I want to congratulate you because you had a very difficult case, you mentioned it. Why? Because it's a class 3 in a female. And I think class 3 in a female is probably the most difficult. After I will show you my skull, you see when the maxilla is retruded and the mandibula is forward, in female it's very challenging to treat it non-surgically. And for me, to be honest, to complete the discussion, we could quite consider this patient as surgical.
Yeah, absolutely.
And always have surgery, not indicate surgery always, but surgical approach, maxillofacial analysis as done by Jenny. So thank you very much and congratulations.
Thank you very much, Yanni. Thank you very much. So we have the next lips, actually. That is lip contour. My technique for natural lips. Jana. Jana, I mean, in Russia, women are not really known for the natural lips. Can you hear me, Jana?
Yes, I'm here.
Wait for a second. So, you might see something different, because I know that Jana is injecting a little bit different than Yanni. So it is also important to you to see different techniques, different patients, different assessments, because we all are different.
Absolutely.
Tatiana, we want 2 minutes because we prepare a patient.
2 minutes, okay.
1 minute, 2 minutes because we prepare a
it's
patient.
fine. So let's see. Refresh. Try to do it. Nothing happens really. So, what do you do for the lips?
We want to say you
Good
that
question.
Yanni is a profi, I know this. And Amsterdam, Dr. Asad is a girlfriend.
She saved you.
But when we speak about Russians, every girl in Russian wants very beautiful and natural music, not big.
I don't believe it.
I don't believe it.
No.
Okay.
Look at all the Russian doctors, for example.
Such as Russian doctors, I have
Or-
very
And
natural.
I will never forget, 2014, I think, we were in Istanbul, and Kyle Seo from Korea was talking about the use of botulinum toxin for the calves and about slimming the legs. And I was with Jana on stage, and Jana took me like this, put her leg, and just said, all Russian and Slavian women have beautiful legs. So that's Jana.
Tatiana, I see it, Tatiana.
Exactly.
And now I want to introduce you my assistant today. It's very important for me because I am from, now I live in Russian, but I am from Ukraine. You know everybody about this. And this is my assistant today, Dr. Fedorova. Please, Ukrainian doctor, expert of the Merz in Ukrainian, and I together. Today is Russian and Ukrainian. We work together. We're very friendship. And our patient, she is very young girl. You may see 21 years old. I think that her lips is very beautiful. And if I have a boy, my son is 29 years old now. But if I have a girl, I don't know, doing like this for my daughter or not. But you know that now we have such situations, such as trends. And young patients speaking with us about lips of some actress, about some fashion. And that's why we must do this. If I don't do this, somebody who don't understand what is it is harmonic of the face, what is the natural of the face, and the another situation. That's why I take 2 preparates, and I want to say that I do this in my clinic in one session together, botulotoxin in one session. First of all, this is young patient, but if patient more older, I prefer doing botulotoxin before procedure. If my patient don't have a time, give me a pencil please, don't have a time, I do it in one session. Botulotoxin here is a white color. Please, you may see a mapping on the face of my patient. And if my patient speaking about volume, some volume of the lips, I prefer first procedure this botulotoxin. 1 point, 1 point, 1 point, 1 point, 1 unit, or sometimes maybe 2 units of Bokutur. If we're speaking about lower of the face and my patient more older, but we speak about natural face, natural lips, I thinking about angle of the lips. It's very interesting what we show Yanni for us. But I work with angle with botulotoxin too. In this situation, I work with platysma. First, for me, this very important line, Nefertiti line, 4 points here. In our Russian consensus of botulotoxin, with Bokutur recommend 4 units for all points, 4, 4, 4, 4, 16 summary. And I work with mentalis and depressor angulioris together because this is antagonist muscle. Mentalis, this levator muscle, and depressor angulioris, this is depressor muscle. That's why when I work with patient with the lips, first for me this botulotoxin. Next one is very important if we're speaking about this zone and my patient want natural lips. This is classical mapping. First of all, I want to show you this place, columellas. I don't work where you see a red color. In these points, I don't work. Why? Because if I want natural lips and if I want upper of the upper lips, I work only here where you see a green color. It's very important places because this place is the upper for the upper lips. If I do where I have a red color, I do another experience. This is not good for these lips. This point is Glagau point, and now when I work, I show you technique of 1 point. I don't do everything. I do only 1 point, and all part of the lips, all part of the lips is from 1 point. And I work with 2 preparates for natural lips. First of all, this is Belatera soft. Two syringe, give me this. I'm sure only. I'm sure only. Don't do it. Yes, thank you. I work with 2 preparates for my patient because I think that very important for natural contour is not so concentrate preparat. This is Belatera soft for me, and I prefer cannula because I understand that we may speaking about anatomy of a lot of time, but anatomy very different. And when we work with needle, all time this is a risk. And if my patient say me, I can't have a bruises, I work with cannula. Yesterday, Tatiana, you asked about cannula 22 or 25, and I forgot to say about this yesterday. I prefer for the face, when I work with radius diluted, I prefer cannula 22, but if the skin very thin, I prefer cannula 25. But if this is danger, maybe in the zone near the nasolabial folds. When I work with neck, I prefer cannula 22-70 because I think that here is very important line of the technique, and this is more comfortable for the doctor, cannula 22. But I diluted radius here 1 to 2, 1 to 3, 1 to 4, not to 1 to 1. But this is my experience. Once again about lips, I prefer here and I work here, will work here with Belatera soft for contour of the lips and Belatera balance with needle for some natural volume for these lips. If you have a question, I may answer for your questions. I don't do botulotoxin here, only speak about this because my patient is very young. And now I want to show you technique from 1 point. First will be needle, this is not comfortable for a doctor when I do show. I understand this because all time this is some risk for problem with the blood. But I think that everything is okay. Now my patient is good patient, and she did another preparat 1 year ago, and she understands what we're doing. Point Blagau, we come into the lips. You will see that superficial. We see how much preparat here, hematizis, and I do procedure. Needle 30. You will see that this is only 1 point. I don't do another point here. And preparat stays to all lips. This is 1. Next one. Not a lot. Superficial here. Zero point 0.05. Next one, this is lower lip, and here I prefer more deep injection. This is the middle line. After we will do here point. .1, and I understand that I don't want to do these lips more biggest, yes, because the harmonic of the face is very beautiful face, very beautiful lips, no small nose, everything is very okay, and that's why I don't do lips more. I want more short lips. And yes.
That's exactly what they do in Asia. They want these kind of baby doll lips, so they inject just the media, cherry lips.
Yes, Tatiana, yes.
And they inject only the media. So if you want actually to make the lips looking smaller but fuller, you inject only into the medial.
Yes, Tatiana. One moment. And very, very small here. I say that this point for the future. Because angle of the mouth is very important point for the future for these lips. You may see that this is a half of the syringe, and now this is I did it with bilateral balance. Now I take bilateral soft and work with the contour of the lips.
So Nana, you're using bilateral soft because you actually don't want to emphasize